CORTRAK. Probably seen it on the unit. Maybe haven't seen it as much in a while, but that's why we're here, to get you trained up and so that y'all can be users as well. I think we implemented like maybe 2.5 years ago. And you should have three handouts. This first one is actually what it's the same thing that hangs on the CORTRAK, so you can actually refer to it any time. But this is basically how I'm going to go through the class, and so you can follow through with that. And then after that, the really important pieces are how you get the tip of that tube where you want it. First and foremost, it's a safety device. I've been an ICU nurse for 21 years, and we always place tube blind. And there's a 50-50 chance of where it's going to go. It's either going to go in the lungs or it's going to go in where you want it to go in the esophagus. And so some of it's about technique, and most of it is just a comfort of the anatomy, especially when you have CORTRAK. So if you haven't placed a lot of tubes, no big deal. If you have, great. I'm not going to be trying to change how you put the tube in. We're still going to do chin to chest. We'll put the bed up about 30 degrees. Some people like to set them way up. For some reason, with the CORTRAK, it's better to have them like at 30 degrees around that area, kind of so all this stuff kind of relaxes and lays out. So even in intubated patients, we do like to even push the head up just a little bit if it's not contraindicated. But anyway, so that's kind of the process that we'll go through, and then at the very end we'll take a short quiz together to kind of give you the highlights of what we want you to know, and then you need to go place tubes at the bedside on actual patients with somebody that's been trained until you are comfortable. Usually the recommendation is 3. That's the AACN's recommendation. But every hospital is different, and we don't direct your practice, but we just give recommendations. So anyway, so let's take a look at the video first, and then we'll move on with the practical portion. This is just an overview of how you're going to set the device up. is up there eating the contraindications. We'll go through some general, relative, and then absolute contraindications when we do I'll do when we do the tracing review. But as far as pacemakers,
Just leave it for now.
any type of device that's like internal implanted, CORTRAK will never affect
We come back to
those devices. Let's say like as far as you giving them a weird rhythm or anything like that.
Hold on. Yeah.
The only thing that we've seen that affects the CORTRAK itself is the LVAD. The HeartMate 3, for some reason, it gives it, the device works on electromagnetics pulse from the receiver unit. And so if whatever device is on the patient is stronger than what this is putting out, and it's in close proximity, then it's going to affect the CORTRAK. CORTRAK won't shut the LVAD down, it won't shut the pacemaker down, anything like that.
General pacemakers are okay?
They're fine.
Okay.
Yeah, and so they're so low and they're far enough away. Usually they're up in this little area here. They're far enough away. It's such a short area
What if they, and you don't see it very often, but what if they have one stomach and, yeah, a pacemaker?
A pacemaker.
You know how
I haven't seen it. We did see a spinal stimulator that was affecting the device a little bit, but we just called the doc and we were able to actually shut it off for the period that we placed, and then we turned it back on. So I usually get a lot of questions about that. I just want to make sure I clear that piece up. So this device, or this document is basically how I'm going to kind of roll through the class. You have three pieces. You got the monitor, you've got the tube, and then you've got the receiver unit. So has anyone in here seen tube placed with the CORTRAK?
Yeah.
Just giving you a nice view. It's a monitor to show you where the tip of that tube is going. So, one thing that the video brought up was that the CORTRAK tube stylet is FDA cleared for reinsertion. They didn't say FDA cleared, but that's unique to this tube. You don't typically replace stylets once they're out of the tube, right? So in the old days, if we placed the tube and it got dislodged, start over. Pull the tube out, get a new tube. That's basically hospital protocol, typically. Well, with the CORTRAK, the only time that you have to do that is if you throw this away while the patient has the tube in place. And the package comes with a bag that you put the stylet in. So, and then what you want to do is put the patient information, stylet, in the bag, and then put it in the room somewhere where a good chance it won't get thrown away. So if you do have the stylet and the tube does become dislodged, or let's say we started in the stomach, they want to go in the small valve, then you can grab the stylet, grab the CORTRAK, put the stylet back in, and push it past to where you want it to go. Does that make sense? You're still going to get your confirmatory x-ray, but hopefully this will eliminate that 5 or 6 x-ray process back in the old days when we placed blind in 10 hours before we're able to feed our patients because we can't get the tip of the tube where we want it. That's the biggest thing.
So you're saying after x-ray, if you say, hey, you need to go a little bit more in, or it shows that you need to go in more, you could just go ahead and put that stylet in and just push it or guide it in more.
As long you put it back on, use the CORTRAK. But that's the cool thing about it. It's a time saver from my perspective. Ultimately, it may take you a little bit longer to get the tip of the tube where you want it, on average, based on studies, about 15 minutes from start of the process to the end. But that's 15 minutes well spent if you're getting the tube where you want it. And then also, as long as you are securing the device. And I'll go through the cord grip. Y'all use the cord grip, but I'm sure y'all probably have fallen off using it so much because if you're not trained, it's not, it's not one of those things that it's invasive. And would I want that done on me? No. But would I want the tube put in 5 or 6 times? No. So putting in the cord grip once and holding that tube in place is a lot better than tape and pulled out and then you have to redo it over and over and you're having to manipulate it. So we'll talk about the cord grip after we get done with the CORTRAK.
I seen on the video that it said it can be placed in the stomach or the small bowel. So it can be we can use this for normal NG tube placement as well as.
If you're using this tube.
Yeah.
Yeah. So back whenever, Dobhoffs came out, this is,
because it's just a small bore feeding
they
tube.
said small bore, but they called it a small bowel feeding tube.
Okay.
And this tube's made out of polyurethane.
Okay.
Your normal NG tube, the clear ones that you can put it to suction, those are made out of PVC, just like the pipes in your walls. That tube actually hardens as it sits in the patient. It gets a little harder as it goes. It's only actually indicated for 72 hours use for medication delivery, suction, and I'm sure we've all seen it, 7 to 10 days. But what they've also found in studies is that they can cause significant ulceration in the back of the throat and down the esophagus. If you ask a patient which one's more comfortable, this guy's a lot more comfortable. So, yes, you can put it in the stomach, you can put it in the small bowel, and it works just fine.
But obviously, because it's a smaller bore, we run the risk of occluding it.
So, what you want to make sure is that you're flushing on your cadence before and after medications. Some of those medications, like Protonics, those things like that shouldn't, enteric-coated, extended release, none of those should ever be crushed up. The reason they convert to them because they're cheaper, and it's and it's easier for the pharmacy to distribute those instead of making them up in IVs. But Protonics is notorious for occluding any tube because if you don't use warm water and you don't crush it up really good, it starts crystallizing almost immediately once you start. And so if you're not placing it quickly and getting it down the end of the tube, it's going to occlude. Even in some tubes, the amount of medication that's left in the bottom of the tube is amazing. I just read a study from Baylor University Medical Center. They did 3 years ago, and the amount of medication that's at the end of those tubes is crazy because there's like holes all up and down instead of just one. And so you just have to be careful, or otherwise, obviously you never use the stylet as a ramming rod to get a clog out. Everything. Just to put coke down on it.
Yeah.
But, so there's probably not a good idea. But, so we've seen a lot of things that we do in practice just for time savers. But yes, you can use this for stomach or small bowel, but just make sure that you're taking care of the tube. When it comes out of the package, just for purpose of shipping, they don't put the stylet and seat it in case the truck that's sending it's hot or something. They don't want it to heat up, and it stick there, so it always comes out. So make sure that you secure it that way. So that's the tube. Any questions? I think y'all use maybe the 12 French. I have to look, but the 12 French inner diameter of this tube is the same inner diameter as a 16 French sump tube. I'll show you. I got a picture of it. I cut two of them I cut them. I got some tube, and then I got 12 French. And I was just looking at it to see what the difference was, and they're virtually the same. It's just the sump tube is a PVC, and I'll find it here in a minute. It'll take me a minute, but
Is that so thick, and is that thick?
it's
material
thick,
that
and then
makes
you also
it
have
look
the
bigger?
air valve, the
Oh, yeah,
valve,
the air valve.
and it takes up space. So, now, that's the first part. The second part, probably the most important, is your receiver. Now this receiver, it'll cast a 30 centimeter web bubble in all 4 directions. So anything that happens above it, below it, left or right, it's going to pick up in a 30 centimeter bubble. So as soon as the tip of that tube, the stylet, comes in within 30 centimeters, this is going to start marking where it's at on this device. So if you can imagine, in order for the CORTRAK to ever be FDA cleared, we had to have an anatomical landmark that was consistent with everybody. So they chose the xiphoid process. The xiphoid process, if you take a look at our clear patient, literally, if this is my xiphoid process, this device sits right on top of the gastric and small bowel region of the patient. So the foot, not the tip of this, the foot goes straight on that notch. You can follow up your ribs or down your sternum, and you find that notch that goes straight on top. Okay? And it needs to be straight and parallel to the spine and taped directly to the patient. You can use this just to lay it on top, but this is not going to keep the tube or the receiver from sliding. So I would recommend additional support. And the patient's got a big belly or they're weak breasted, either way it's got to be parallel. So you can actually put wash rags underneath to level it up, and that's just what we do. It'll still shoot through all that. It'll shoot through bandages, it'll shoot through surgical sites, any of that stuff. It'll shoot through all of it.
So it needs to be flat
Yep.
against the patient.
Level, so anywhere this goes, and parallel. So if I want to hear
Okay.
here, I come in here and y'all are doing this, y'all didn't listen. It's gonna look weird. And so this is the important piece of it. Now, any questions on that? All right. So if we're doing a new placement, you have to put the patient's first name, I'm just gonna put test, and then their ID or whatever medical record number, and next. Don't let me forget, at the end, we need to put your names in here as
Yes.
users, so that you can use it. You don't wanna give that out, you're gonna give your own unique password, you don't wanna give it out to anybody for obvious reasons, but I have to state, if you do give it to somebody and they use it and they don't know how to use the device and they cause an event, it's a whole big thing. Most hospitals, that's a termination immediately. So don't do that. And don't let doctors take control of it because they haven't been trained on it and they think they know, but they sometimes don't. Some of them do, but have them go to the class and they have their own login. So first thing that I want to bring up about the monitor, this is the third piece, are the 3 screens. When you take and send, when a patient they come up and do an x-ray on a patient on a blind placement, they get our KUB. Anybody know what that means? Anybody remember what that means?
What is it? KUB?
Kidney, ureter, bladder. It's just the lower part of that, or the chest X-ray, KUB, top one. And so you're only getting this 2D view, okay? They're only going to be able to see what the screen gives them in a 2D view. This is the same as the KUB. It's going to give you the same picture that the 99% of the time, this correlates with your x-ray unless the x-ray's done 3 or 4 hours later and that tube has been pulled further into the small bowel. It's the only difference. But you're going to see the same thing on this screen. That is your anterior view. You also have a lateral view, which my recommendation when you're placing is once you get set up, you have your anterior view and you want your lateral view. And you'll know why here in just a second. I'll explain it. Your lateral view is just that. It's the lateral view of the patient. You kind of look and see the esophagus. It's kind of bent, runs right behind the trachea. Sometimes they're bent on the anterior as well. And they just, as age, as you age, things just bend and get out of whack. And so, if you notice, the distal portion of the stomach, which is right here, that sits right underneath our receiver, right, is the place, if you're going to do a gastric placement, that's where you want the tip of that tube to be. Why do y'all think that?
So that way it doesn't cause any ulcers or.
The aspiration.
Correct. So you've got two sphincters that you're dealing with when placing these tubes. You've got the gastroesophageal junction. It's also called the esophageal sphincter. It's also called the cardiac sphincter. So they need to figure that out. But we're not going to figure that out today. But that's the top sphincter, and then your pyloric sphincter. That's the sphincter between your stomach and your small bowel. You want to set the tip of that tube down here to reduce the risk of aspiration, especially if they're intubated. Also, if you can get into the small bowel, then you got a double protection against aspiration. And so that's where you want to place the tip of that tube if you're going to do a gastric placement. And then, so that is your lateral view. You're going to see a nice curve up, and you see the most anterior part of the stomach is the distal portion of that stomach. And so your tube's going to climb back up to underneath your receiver. And then once we get into the small bowel, we're going to get what we call the drop. And that's when you want to transition over to your depth cross-section screen. Think of your depth cross-section screen as like your CT. It's looking at the patient from both top and bottom. Okay, it's looking at everything that's going on, placing this tube from the top and the bottom. But if you notice, when you get into your duodenum, it's a C shape, and it's facing like this down. And so you'll get a drop. The only time you're ever going to get any tracings on this is if you're in the small bowel. That's the reason we want our lateral view up first. And then we go to the small bowel, and then you'll see that drop. You'll be able to see all the portions of your duodenum and into your jejunum if that's where you need the device to be. Does anybody know the most common population of patients that need jejunal feeding? Absolutely. What kind of patient is that? They got a disease state.
Absorption.
They will get very sick.
Malabsorption.
So you want anybody that's got pancreatitis or pancreatic cancer, the doctors are going to want to feed in the jejunal portion, because if they feed anything back up into the stomach, they get very sick.
Oh yeah.
Because they get that enzymatic production and it makes them very sick. So, and we're trying to let the pancreas rest. That's just one example. There's a few others. Absorption percent. Does anybody know what the main things that are absorbed in the stomach? A few trace minerals, water, and Whataburger, Saturday night, alcohol. Okay? So alcohol is a big player.
I said facts.
About 30%, about 20% of all your nutrients are absorbed in the duodenum. About another 30% is absorbed in the jejunum. So the majority of your absorption takes place in the upper portion, back into the patient for nutrition. So that's kind of the reason why when dietitians know that this is in-house, they know that they have the ability to feed at the bedside quickly in the small bowel without going down to special procedures to get it placed directly in the small bowel, which is kind of a waste of resources anyway. So the CORTRAK keeps having that. So those are the three screens: anterior, lateral, and depth cross section. Depth cross section, remember, the only time we're going to use it is once we get into the small bowel. You shouldn't have any kind of tracings otherwise on the depth cross section. Okay? Any questions? All right. Now we're going to start doing some placements. So if you notice, this is really long, and when we first bring the tube out, they're like, "That's crazy." Well, that's just our tether to the CORTRAK. And so there's two arrows. There's an arrow on your stylet, and then there's an arrow on your interconnect cable, and they just click. And when you want to when you want to disconnect, there's just two clips on and you press them in, and it just pulls out. If anything's going to break on this device, it's going to be because you're tugging on that. Make sure this doesn't get wet whenever you're flushing the tube for the first time. That video shows that you flush after. We're going to flush before. The reason is because there is a lubricant on the inside of this tube, and once it gets wet, it's what activates it, and this will allow you to manipulate this stylet a lot easier during the placement. There is also that same lubricant that is on the tip of this tube. If you dip it in water and gloves on, obviously you can feel it. It gets really slimy. I know everybody loves to just take lube and just freaking go crazy, but just remember that all gets caked up. So you just want a nice, layer of lubricant that'll let the tube slide down nice and easy. And you don't have to have it all the way up to here. Just kind of, down the first 6 or 7 centimeters.
So it's not the more lube, the better.
No, because it actually, like, especially if they're awake and alert, it'll actually clog up their nose and it's just full of
Wrong
hell.
class.
Just making sure.
So, all right. So we're going to flush first, and for the sake of placing on our belly box, I've got to take this out of the tube, but I also have to disclaim that that's not what we're going to put in the patient, okay? I'm telling you, I've done this whole thing for an hour and a half, and then somebody raised their hand, like, how do they feed into that? I'm like, how'd you get through school? All right, so we have, get where you can see for sure. Ideally, what I always recommend is the device be on the other side of the bed so I can see it. It's one of the few times that you're actually watching a monitor when you're doing something to the patient. We're always taught in nursing school that you got to keep an eye on your patient, but I like to have everything in front of me. I like to have the monitor. If they're nice to you, I want to be able to see everything. Especially, just remember there's no such thing as a stat tube feed placement. So if the patient cannot tolerate being off of oxygen and you don't want to take them down to 80% and then it takes them 4 hours to recover, and hopefully you don't have to re-intubate. We don't want that. So just, it's the right time, right? So just make sure you're thinking through that clinically. So what we're going to do, there are centimeter markings on this tube. I recommend that you're going to grab the tube at 10 centimeters, and this is how much you're gonna put in their nose before we press start. The reason I want to be very precise on that is if you just place the tube and you're 15, 16 centimeters already in before you press start, you could already be in the branches of the left or right main, branch of the lungs. Around 15 to 35 centimeters is where that danger zone is, and I'll talk about that on the screen. Your anterior screen is broken up. This is the patient's spine. This is their diaphragm. Left lung up in this quadrant, right lung up in this quadrant. Once you get to this region here, that's that first GE junction, that first sphincter, and you're gonna see, not always, but on this device, you're gonna see a nice big, perfect stomach. Sometimes their stomachs are flat, they haven't eaten. Stomach's just a reservoir, there's nothing in it. It's gonna be flat, so we may not get that beautiful stomach. And we'll show examples of tracings. But you're gonna see go around, and you're gonna get to this point here. Now this'll be more transparent. This won't be as here, the receiver. Once you get back to this line on this lower quadrant, that is your pylorus. So the big landmarks, lung, stomach. Now some people's stomach will go way up, back up into this region, but what we're doing is looking here to see how deep we go here to make sure that we're deep enough past that 35 centimeters that we're way down, and we are in the esophagus, but you will see that. And there's various reasons. They're large abdominal girth, pushing stomach, everything back up into that region. There's other reasons as well. But once we get to this point, we're at the pylorus, and then once we cross over, you're going to see it go into the small bowel, and that's whenever you would toggle back over your depth cross section. You're going to see it go into the duodenum and over into the jejunum eventually, and I'll talk about that, what that looks like here in a second. So I'm gonna place this tube in. Like I said, I'll grab the tube at 10 centimeters. I'm going to place it in their nose, and I'm going to press start here. If it's easier, you can press it here as well. It's going to say energizing stylet, meaning it's figuring out what all's going on. If this is blinking, that means it's working. It's thinking. It's looking for the tip of that tube. And then we get out of range. Out of range is a good thing. It's telling us we're not so far down the esophagus that we may be somewhere we don't want to be. So I'm going to start placing, and this is not a race. We're not like, hey, how fast can we put this in the patient? We want to be consistent, not, because I've been with some clinicians, they're just like boom, 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 just as fast as they can. I'm like, where are you? Well, you're way in the lung. And so you see that little green ball, that's the tip of your tube. That yellow line is where the tip of that tube has been. Don't confuse it with that being the tube, okay? That's just where that tube has been. It's tracing where that tube, you ever watch Bugs Bunny, where he digs a hole? I mean, it's kind of the same thing. Bugs Bunny, and then the holes where, never mind. I used to watch cartoons, I don't know. So anyway, so where are we now? Right there at that GE junction. Yeah. And so we're going to make a turn back up. We're going into that fundal portion of the stomach, into the greater curvature of the stomach, around, nice, pretty, big stomach, and then we get back to this portion here, and I should have had this here as well. But if you notice on the lateral screen, you see how I'm dragging back up towards the receiver, which is the distal portion of the stomach, which is the most anterior organ in your body. It lays right underneath that region, and it's going to pull all the way up until I get right there. And you kind of see it kind of turn and drop down. That is at the pylorus, or they call it the duodenal bulb. And then you'll see, you'll start seeing tracings. So like, I back up, there's not any tracings. This is also a depth finder. In other words, this is where you are deep in the stomach or in the body. So it's telling me, this line is telling me where I'm at, depth-wise. But you're gonna see cross. And there is where it entered the duodenum. The duodenum, like I said, is a C shape. It's divided up into 4 quadrants, D1, 2, 3, and 4. You want to be at least in D2, and we'll talk about where those are. It's not something that you need to fixate on like charting and all that. You just want to make sure that you understand what you're seeing. But you're in right here is the bottom half of the D2. So D1 is here. D2 is kind of that drop down. D3 is the start right here. And it goes, when you get past that, that is D4 when it flattens out like that. And when you get to this tick mark right here, that's the duodenal-jejunal junction. That's where it's leaving the duodenum and going into the jejunum. Does that make sense? And now, where it's deep is where we're going to probably ever get or need to get, but that's a good jejunal placement. There's an anatomical landmark that we use called the ligament of Treitz. You may know what that ligament does. It's an actual ligament. It actually attaches to the musculature of your abdomen, and it holds your small bowel. So it's not just flopping. So it kind of holds it up in place. It's got no function whatsoever for digestion. It just holds up the small bowel in that area, which is right there at the ligament of Treitz. All right. Any questions? Really pretty. See the drop here? And so there's one more step that we do whenever we're placing the tube. So the tube is in the patient, and what we're gonna do is we're gonna press in, and we're gonna do what we call a retrace. And you'll understand this intimately once you start using the CORTRAK. Remember I told you the tip of that tube, that's what that yellow line represents. Now, during that time, there may have been time where you're placing tube and tube's coiling somewhere. So what we want to do is take the stylet out of the patient, okay? And until, what you're going to do is you're going to crimp this tube. So this is in the patient. You're going to hold this is at the patient's nose, and you're going to pull this out till you feel the end of that stylet. So that stylet's got a little bulb on the end of it. You'll be able to feel it. You'll be able to feel it once it gets there. And so then what you're going to do is you're going to replace it back about 10 centimeters, and then you're going to do a new placement. All this is kept in the device until you change patients. And you're going to press start again, and we're going to just do a trace with just the stylet. This is in the patient, and I want to confirm I don't have any areas where I'm looped or where I am coiled, because what's going to happen, you're going to get an x-ray, they're going to read it, coiled here, pull back so many centimeters. You're going to delete that step from being then, you're going to do it all right now. It takes 2 minutes. You go, all right, let's get a retrace, let's make sure we're where we want to be, and then you're going to treat it just like a placement, except the tube's already in the patient. When you're done, you press in, and then you pull the tube out, and you put it in the baggie.
So you wouldn't have to pull back on the tube at all?
No, the tube is already in there.
Mm-hmm.
Tube's already in there. And the reason I want to do that is I want to make sure I don't have any coils or have that tube somewhere where I don't want it, and I want to take the slack out and I'm gonna take care of all that right then.
So is that the reason why we're flushing before, so that we were able to maneuver it a little bit better?
Exactly.
Is there any contraindications for like, gastric sleeves, IBM?
Good question. I'll get to that in the presentation, but it all depends. If they're a brand new, you know, if it's brand new, probably doctors and surgeons are probably not gonna want you punching around. If it's old, yes, you can still use it. But I've got some examples that we can look at that you'll be like, okay. Any questions?
How long do you have in between patients to like print if we need a reprint or like this?
You can always, under your name, if you're the operator, you can go back and print anytime. Because what you'll do is you'll go back to, and it'll say placements. You go into placements, and then you can look at any placement that you've ever done. All right. So now let's take a look at what we don't want to have happen. And so I'm ready. I'm gonna transition over to my lateral. I'm gonna press start. Got your patient ready. You start placing. Out of range. Everything looking decent so far. Where do you think it's going? Which lung?
The left.
Left lung. Okay. A couple things. Everybody's bold in here, hopefully at some point in their life. Bold. Okay. These two tick marks. These are your gutters. Once you're outside of those tick marks, when you're placing, you're in gutter land. You don't want to be there. You get 0 for being in there. Same thing with the CORTRAK. Once you're past there, in these upper quadrants, way up high, you're in the lung. Okay? So each one of these tick marks is about 7 to 8 centimeters of tube. So if you could think about it, once we're at 3.5 to 4, once we get below that, we're kind of out of that area of lung. So like I said earlier, if it starts deviating here, just sometimes you'll see that deviation and then you'll see stomach come way up here. Well, we know we're not because we're going to look at this as well. And I'm going to show you kind of what that looks like in a second. But either way, one tick mark, either way, you want to stay within your bowling lane and don't get in the gutters. And so if I didn't know what I was doing and I kept placing, okay, kind of see the difference, really flat. Doesn't really go anywhere, okay? One caveat about this, if we've used washcloths or anything to elevate this, okay, this tracing is going to look a little bit lower. Why? Because we've gone further away from the patient's actual body. Does that make sense? So you're going to see this kind of be a little bit lower, but you're still going to get that push up. It may not go all the way up because we've elevated that because we wanted to level it out. So just remember that piece. We'll never get to this point because we've got CORTRAK. If you didn't have CORTRAK, this is the point where you could give them a pneumothorax. You could cause nothing. It could just be in the airway. However, we eliminated that right there. That's the good thing. So we're gonna actually pull this back. I'm kind of show you, like, remember I told you that bubble goes above? You can, if you had one of these at home with your kids, you could actually they can play with it like this. But it's just, it'll pick up everything above. So if you're like about to, if you've already pressed start and you're sitting there talking and you look over and it looks like that, it's just because it's outside the body. Just a bunch of artifact. All right.
I have a quick question about the alignment. So if we already put the sensor on the patient, we clearly see that we have it midline, but the patient's anatomy may be off as far as like esophagus. Do we just stop completely? If we see it going down to that like 4 hash mark, do we
So you may have a bend in your esophagus. However, I'm going to use my tick mark. It may push all the way, but if it straightens up,
Oh, it's still okay.
you're okay. Good question. You don't want to be just like so crazy over the top that you never place a tube, but you want to be cautious. But you're like, okay, I've seen this before. Once you've placed a few, and it starts coming back, then you're good. It's going to be, the deviation is going to be pretty consistent on all of them. For some reason, it likes to go in the left branch, and what's funny is the left branch is at about a 45-degree angle, and the right's about a 20, so it's a little straighter. But remember, on that side, this side, there's no stomach, there's no anything. So if it continues to deviate off, you're like, okay, this doesn't look good at all. This doesn't look right. Pull back. So that's the reason I'm always like, know what you're seeing on the screen. This is, not just procedural. Like, I'm going to do this. I'm going to do this. Know what you're seeing. Okay. So let's take a look at this. Out of range. Looking pretty good, right? They bubble change that over. Right, so I've got my kind of a little bend going. Everything's looking pretty good. Kind of pretty much out of the woods as far as being in the lung. It's a little different, but that's okay. Just because it goes straight down and not on the greater curvature of the stomach, that's okay. We still may be all right. However, we're not. We're kind of coiled. So, in order to remedy this is what I call a visible coil. And I'll show you one that you can't see. It's kind of, I call it invisible. I'm going to pull back to about right where the coil started, about right there. And there's a couple things that I can do. So if this is like you're in the stomach, the patient hasn't, regardless if they've been fed or not fed in a while, sometimes it's just the stomach needs a little bit of air. And it is acceptable to put air in the stomach. I would start with, in the stomach, 60 cc's. And you're going to place it on the med cord, the white cord here, and you're going to put it in the stomach, making sure that this is seated. If your stylet's not seated and it's out, your air is just going to shoot right out at this end. Okay. Same thing with doing meds or anything like that. Make sure that this is either connected or it's closed. But you're going to give them 60 cc's, and then what I do is once I give the 60 cc's of air, I'm going to give it a little quarter turn. So it's going to look a little bit like this. So I'm just going to give it a quarter turn. What I want to do is try to get the tip of that tube to kind of move up and where I want it to go. Okay, it works sometimes. Sometimes I have to use what they call a floppy tip, where I'm actually going to pull about 5 to 6 centimeters out of the stylet, which what that does is allows the tip of this tube to kind of flop, and then I'm going to advance the tube with the stylet out about 3 centimeters, and then I'm going to start placing the stylet back. What I wanted to do is I wanted to kind of do this and then kind of get where I want it to go. Okay? It's the same thing that the GI doc would do if they went down to Florida to have it placed. You can kind of see it happening, and I'll kind of show you what it looks like a little bit. But does that make sense? So that's a visible coil.
Can you flush that with
place this. This is a good placement. You see right here, we're gonna get a drop. So this is where you're gonna kind of spend a little bit of time. Pylorus only opens so much a minute, maybe 2 to 5 times, just depending on the person. So it'll open, take a bolus of food, or we can stimulate it. Meaning we can take about 40 cc's of air, and if we're sitting right there, as I inject that air, I'm going to hold pressure on that stylet. So you can on the tube, you can use patience and wait for it to open, and you'll kind of see this little ball. It'll be just sitting there doing this. It means the stylet's always kind of the pylorus is always kind of moving, but then you'll kind of see it bobbing back and forth, and then next thing you know, you give it a little air, and that's kind of mimic a bolus of food. And then you try to advance a little bit and see if it pops through. And if it does, victory. If it doesn't, again, patience, air. You don't have to go in that order. Or we can do the floppy tip. What I'm going to do is I'm going to pull this out, kind of just so I can show you better. It's hard to do it without the tube. So. All right, so this is in the patient, and it's the tube sitting right there, and I am placing tube, but that ball is not moving. What do you think's happening? It's coiling somewhere, more than likely right behind the tip. Okay. Now intubate it, could be coiling in the back of their throat, so on and so forth. But you're not going to see it because the ball's not going to be moving. But you know if you're placing tube, it's going somewhere. Okay? So what you want to do in that situation, if you put in 5, 6, 7 centimeters, you want to pull out that slack until you see that ball move back. And then you want to stop. And then the best way to get it into the pylorus, if you're sitting right there, is I'm going to hold pressure, and I'm going to, and the best way to do it, especially if you're by yourself, is just like I'm doing it. Grab the tip of this tube, pull back, okay, and then while you have it out, you're going to push tube in, because so I'm like, so you kind of see how it becomes really flexible, pliable. So what I want to do is hold pressure, and as I advance this tube about 3 to 5 centimeters, I'm going to crawl my stylet back in. What I want that tube to do is kind of do that, and then pop on the other side. It's going to do one of two things. It's either going to pop on the other side, or it's going to make a turn east or west, because you're going to be able to see it's going to coil. Because you're not going to get that pretty drop. Basically, what'll happen is you'll get a coil, and it'll coil back one way or the other.
And you're still talking about at the pylorus,
Yeah.
right?
Yeah. Some clinicians will also put pressure and then advance 2 or 3 centimeters, and then they'll go boom, and they'll slam it in. It's just, you can use either one. When I say slam it in, they're not like but they're not slow like I was on that first one. So you can use one of two methods. And then the last one, I don't really see it working a lot, but it has worked before, is you're trying to stimulate the pylorus with the tip of this tube. It's just kind of going back and forth. And all right, middle school version of the class, they tickle the pylorus, everybody giggles, and then we move forward. But you can actually do that by just kind of going back and forth, and the actual tip of that tube is just sitting there doing that. sometimes it works, but you have to hold pressure. If you're not holding pressure, it's just in the stomach doing that. So those are the main ones. Those are the ones that work 90% of the time, based off studies. 86% of the time, to be precise. Any questions on that? So your points in the stomach are the coiling early, the visible coil, the invisible coil at the pylorus. So you got patients that you can just hold pressure until it opens. You can use the air bolus, and you can use the floppy tip or stimulating the pylorus. Those three things. Typically, if you're sitting here 25, 30 minutes and it hasn't opened, guess what? Ain't got nothing to do with you. It's just the patient. And sometimes you just have to leave it right there at the distal portion of the stomach, and hopefully it'll start rolling in. Now, if you have to have it small bowel, we'll just keep trying, but you just don't want to be sitting there more than 25 minutes. If you're at 25 minutes, stop, leave it there, let it sit, come back in 30, 45 minutes, and then try it again. Because sometimes, especially if the patient's awake and they tense up, it makes everything tense up. Believe it or not, they're like, because we did one. We were down in the valley last week, and the guys just, all over the place, clamping down. We went back the next day, and it was slid right in there. It's just, anyway. So it's, sometimes they're just that way. Any questions? None. I must be done. All right. So, that's where, who asked that? You did. This is where you can go in and look at your placement history anytime, okay? Now I went into admin, and I can see everybody's, but it'll just be yours or yours, whoever's, right? Now, one more thing really quick. If you're kind of just like, you go in, you place a tube, maybe so you say you're by yourself, and your patient is moving around, agitated or whatever, and you go to start placing the tube, press start, you're here. Toggle over to the lateral. First of all, if it's way on that, well, it's way off. Let's just say it's here. Let's just say it started down the middle. Where are we? Huh? We're in the lung, correct? This tells me a little bit, really flat. The second thing is, this device is going to read opposite. If it's too high, it's going to read too low. Make it make sense in your head so you'll remember it. So if it's really high, it's going to track sooner, because you're probably not going to get the out of range if you're super high, because you've already flooded the nose into it. And so you're not going to get the out of range, and it's going to read lower because it started reading sooner. Make sense? Mm-hmm. If it's way down here, you're going to get out of range for a long time until you get in that, and then you're going to pick it up. So if it's too low, it's going to read really high. It's going to read way up here. You may be in the right spot, but your receiver's too low. Mm-hmm. Same thing. If it's too far to the right, it's going to read too far left. Too far left, it's going to read too far right. Everybody understand that? And understand why? Perfect. So I want to make sure that everybody sees that piece. And I think that's about it. As far as all the things, if you're in the small bowel, what's the difference between the gastric region, the stomach, and the small bowel? We got an air in this stomach, positive pressure. You can pull secretions out of the stomach. Is there a reason why we do residuals in the small bowel? Why? It's negative pressure. Once you get in the pylorus, it's locked down, and it's negative pressure. So if I pull back, if this is on my patient and I pull back, it's just going to snap back. Okay, you can use that as a test, as a secondary. You know, it's not an absolute because it could be up against the stomach wall when you pull, but it's not an absolute. If I just want to confirm kind of where I am, you can pull back. But also, for that very reason, if you're going to inject air in the small bowel, it needs to be no more than 25 to 30 cc's max. Why? You blow up that small bowel, they're going to be freaking in some serious pain eventually. And it's going to come out eventually, but you don't want to put that patient in pain. The only time you're going to do it in that D2, if you want to get around that corner, you definitely don't. You want to try not to, if possible, to leave the tube in D1 because it could potentially retract. So if you get around the D2 down in this region, you're in pretty good. So if you want to get around that corner, about 25 cc's of air as you push. You can also use floppy tip. Floppy tip works really well too. Okay, you can do that. Any questions? All right, let's take a look at some tracings real quick.
See it?
Yeah. So these will start making a lot of sense now. So in case you had any questions, this is just talking about receiver placement. Just make sure that receiver at an angle of 20 degrees or greater relative to the patient's spine, or at the front of the foot receiver's position at a distance of 10 centimeters or higher, you're going to get a different picture on the screen. Okay, so it's got some variability, but just want to make sure 20 degrees is not much. Okay, so you want to make sure you're level, and you want to make sure you're on that xiphoid process within 10 centimeters. Not very much, but there is a little bit of variability. All right, quickly, we're talking about just your three views. You're going to use all three views to figure out where you are at all times. So anterior view, notice mid esophagus, but I stayed within my range. Okay. Not a really big stomach. And so anterior, and I go to my lateral, pull a nice big curve. Not all of them are that curvy. Some of them are a little flatter, but eventually they will crawl up. Right there, distal stomach, down into the small bowel. Okay, so we get that? Okay. Since I have tracings on this screen, I'm in the small bowel. D1, 2, almost to D3. Okay, so that's your depth. That's the depth cross. That's how you read kind of all three of them.
Does it need to cross that line?
It's here.
Yes. Does it need to cross the y-axis?
Like for example, if your receiver's too far right, your ball's going to be over here, and you may be in the small bowel, but it's not going to read because it's not gonna see it as it's active, as the device is working. As soon as you press stop, it's gonna show everything that the device has seen from the foot. So you're gonna see a bunch of squiggly, which is not very helpful, but yet you will not see, if you're lined up correctly, you will not, you won't see anything on this side. Only time you'll see anything is if you're in that small valve. That's the indicator of getting into the small valve that makes it a little bit different. Lung placements. We're gonna beat this to death, but it's very important. Again, outside of my guardrails or my bowling, the gutters, this one went really way too far. Nice deviation right there. You see that? It's a really sharp 45-degree angle on your secondary focus. Obviously, you're not going to have anything here because you're not even close to the small valve. Again, little smiley face. This looks like this was one that the receiver was elevated by a cloth because it was really low. But regardless, it's still going to give you that smile. And this one kind of is down, but it stays flat. And so, lung placement, gastric placement. And then obviously you would stop right here on that. Pull back and readjust. Some contraindication, you know the difference between an absolute and relative contraindication? Bless you. Absolute is don't do it. Absolutely don't do it. Relative is clinical indicators show to be cautious. Okay, it can still be placed, but we're going to take that patient's individual situation into consideration before we do so. If it's a fresh GI, bypass, we're not going to do it. But if it's 5 years old, 10 years old, not a big deal. Nasal polyps and other things that may get in the way of placing your tube. Sinusitis. There are studies that show that tubes, any tube in the nose can cause sinusitis. I'm like, well, yeah, but so can anything crawling up that ET tube if they're intubated. Anyway, it is. But those are some. Bottom line is, if you get asked to go place it on somebody else's patient, ask some questions. Okay, not that you will, but I'm saying if you do, ask some questions. Make sure you know what their situation is. If they're active esophageal varices, no. But if they have a really low platelet count, no. But what is that? What is your policy on placing? You need to know that. At MD Anderson, it's 20. In other places, it's 50. So it's different. So know your policy. Okay. You don't want to cause a bigger problem just by placing a feeding tube. This is what I was talking about at LVAD. Right off the bat, see the tubes coming in from the side? The receiver's confused. It's getting, think about it, the LVAD is right there in the left ventricle, and it's sitting there pumping, and it's putting out all that, anything that moves, water, anything causes an electromagnetic pulse. And so it's going to pick that up. And if it's greater than what the machine's putting out, which was by design, because the last thing we want to do is shut down the LVAD, it's going to take it over, and it's just picking it up right there. And this, you don't do LVADs, do you? Anatomical anomalies, this is what we're going to look at real quick. Again, real quick anatomy review. This is what you're seeing on the depth cross section. This is the pyloric sphincter, D1, D2, D3, going into D4. D4 gets to this point, that first tick mark. Once you go past that, you're in the proximal jejunum, right at the ligament of Triton's. Okay. You want to see something pretty alien? This is alien. But the design of it literally, you'll see it kind of come out, pull, come out, pull. Kind of does that. There's a reason it's not always open. So, and now it just kind of retracts back. It's close, close, close. Remember that patience? Oh, now we're going to open up. If you hold pressure and you have patience, that's where it will kind of sneak through. Does that make sense now that you've seen it, at least? A little bit? That's pretty cool. It's not in everybody's presentation. I'll probably get in trouble. We've already talked kind of about this one, but look, you notice no stomach. You could go straight down, take a right. Went right through the duodenum. Where's our drop? Representative of that spot right there. And really deep, almost to right there at the end of the duodenum, the first jejunum at the ligament of triton. And then obviously here as well. Posterior duodenum. This is the one where probably your radiologist is going to read it as coiled in the stomach, but in reality, it is duodenum is just posterior. It's in about probably 30% of the population. It's not a, don't call the doc, they don't care. It's just an anatomical variation for various reasons. It's just that the duodenum, instead of sitting there like this, it's rotated back. This is what it'll look like. It'll either go straight back or this will go up. But you have to take this. You got to look at this one to know where you are. You see the drop, and then obviously your depth cross section. Hiatal hernias. These are tough, but they can be done. For some reason, the tip of this tube likes to go where it doesn't need to go. But it's going to go up into the hernia. This is where you would use this floppy tip to get that turn and get it back out of there. There's different variations. Sometimes they're undiagnosed and you'll find them in placements. Sometimes they're not. I mean, sometimes they know. So you'll know going into it. But this doesn't mean you can't place on there. It's just a little bit of patience, and getting around this curve right here is the big one. Okay? But this one is another one where you want to use that floppy tip because you want to push up, you want the tip of that tube to do that, and then ease that tube back in there and then get going so you're exiting that hernia. Scoliosis. The esophagus does travel the same path as your spine. And this is from an actual patient. And you can do a couple things. You can use your rules and proceed, because I didn't ever get out of my barriers. Or you can stop halfway down and get an x-ray and then advance. It's up to you. Use your clinical judgment. Okay? If you know they got scoliosis, then you know it's going to do some squirrely stuff. Okay? What do you think that is? That little tip right there. Tip right there. What do you think the reason that happened?
The length, because it's 30 centimeters, right? So if
So,
it's within.
When they started this, they had them really tucked and probably sitting way up. So the tip of their nose dipped into
The range.
the range, okay? So don't let that freak you out. It may be way over here, but if it's going up and disappears and then comes back, you're okay. You're not in the lung because you don't have enough tube in there, right? So don't freak out. I just want you to know that sometimes, based on what we do to manipulate the patient, it may go into that area. Gastric sleeve, lap band, gastric bypass. I swear for a while I thought they were giving these away for free because everybody got one. And then there's a guy, remember Dr. Kim, Dr. David Kim? Man, he had I think he's about to go to prison for fraud, Medicare. Yeah.
I didn't can get one
They
before
were,
you went.
he had a huge place over, right off of 75, right across the street from Medical City. And they went in there one day and cleaned house. I mean, the OIG, the Office of Inspector General came in. He was under investigation, him and all of his partners gone.
That's
Now-
Forest Park Medical Center.
Huh?
Forest Park Medical
That's
Center.
right. Now it's Medical City Heart and Spine.
Yeah.
And so, it's a beautiful building. I mean, spared no expense, actually. So, gastric sleeve, same thing. Look at it, how fresh is it, how old is it? These are pretty easy. You don't see these a lot, but you may. These were, like I said, very common. It all depends on how tight they had the lap band. And this, think of this like a speed bump. It's just getting over. So using your techniques, pulling back, floppy tip, just getting over this area. Because I've had one where it just hit and kept doing that. And eventually we got to go through. But those can be tricky. These, not so much. These are pretty straightforward. And there's an example of a duodenal placement. This is an example of a gastric placement. Remember, their stomach is literally no bigger than their fist, or about the size of a lemon. What they've told me. And so you're not going to spend a lot of time. Real quick drop there, and right here is a gastric placement. Just terminates into that little bowl, which is now their stomach. But you can place it. Their problem is they go through all kinds of dumping syndrome and all this stuff because you're getting food that hasn't. Anyway, I mean, it is what it is, but so there's a lot of, if you have any questions, get with your dietitian. They know all about these. Ascites, remember, patients that have a really big belly, if their livers, just making sure, just level up. You can still place it on these as well as pregnant patients. You can place tubes. Just make sure they're level. Okay. All right, little game. Where's the tube tip? Number one, using all your screens. Start with your anterior and your lateral, and then we'll move over to the right side. So, are we in the lung? Right, agrees that we're not in the lung.
Right.
Are we in the stomach? Well, we kind of are, but not determined. We didn't end there. Are we in the duodenum?
D1.
Yeah, right at D1, right there, close to D2. Yeah. So we're not deep enough to be in jejunum, but so we're in D, the duodenum. Everybody could agree? Okay. Oh my goodness. Where are we? Say it out loud. Huh?
Try to go back up
Is
to
it-
oil.
I was just gonna say at the top of the stomach.
Maybe. Where else do y'all think it is?
Left lung.
Huh?
The lung.
It may be. Where else? Their toe? Maybe.
Yeah.
We don't know. Why?
It's
Because
not
our
centered.
receiver's too low and it's twisted. As soon as you see this here, you look down at your receiver, okay, and go, okay, we're way off. Let's straighten up. So you wouldn't go this far. Now, if we just turned it, it's probably a great placement. It's probably distal stomach, but you definitely don't want to. Continue because you don't know. You'd stop, readjust the receiver, and then get it back on track.
So if it was in the lung with the lateral, would it be higher up? Or,
Here,
yeah.
probably wouldn't have climbed as high.
Yeah.
It may have climbed here, kind of skirted around,
Okay.
stayed pretty low, but you probably wouldn't have got this. Yeah. And you're not going to get anything here because you're off center. You're too far right, which means it's going to read way left. Start with the anterior. Looks a little weird, right? You got a really bendy esophagus. Could be for various reasons. 80-year-old, 90-pound lady. Could be they have a really huge boggy heart. Really big one. If it's deviating the esophagus, probably just age. But we stayed in our guardrails. This right here makes some people a little nervous, but look how far down we are. We're probably like at 40 centimeters, probably. Remember, on the anterior, that tube may go into the stomach and go posterior, which may make it, because if you take a look, if you see this, even though this is a 2D view, that tube came in and started moving back anterior. Does that make sense? And then it's going, I'm going the wrong side of my body, but then it goes in the right way. So it starts going towards here, which we got what, our drop? So where are we?
Small valve,
Yeah, exactly. We're off. On one like this, hey, you're spot on. Straight up and as far as where you're at on the body, it's just this device has moved over. Not very much. You can center that up, and I mean, this is a nice posterior duodenal where it's sitting like this, but we don't know. So I would adjust this and see where we are, and then get a retrace. The one before, crazy, off center, all that kind of stuff, confused. But what do you think caused this?
Too far over.
The gap.
Oh, the gap.
Oh,
It's early.
Late. So that's like, okay, they started, and then like, oops, my green light's not blinking, I push start. It's just a late start. What's a little bit, can be an issue from a late start is you don't know where you are. You may be already in the lung.
Would you just stop, push the end, and kind of just start the whole process over?
What I would do is I would push in, adjust my receiver, pull the stylet out, retrace what I have, see where I am. Because this one's not so squirrely,
Yes.
where I don't want to pull the whole tube out.
Yeah.
Okay? Because if you pull the whole tube out, you got to put the patient back through the process. This one, use your clinical judgment. If anything, if you're like, I have no idea where we are, just pull back. But this one, really nice lateral, and then once you do your retrace, that's the beauty of the retrace, is you can retrace it and be a nice, beautiful D, probably D2 or 3. Yes.
So it looked like a coil, but is it in the duodenum just because it goes downward on the lateral?
Yeah, this is that one where your radiologist is going to read coiled in the coiled in the stomach.
Oh, okay.
But you can actually roll it down and say, hey, based off once you get a good reading, once you get a good trace, roll it down and go, we're in the duodenum, I did all the stuff, pull back, got a snap test. They may not change. However, if your doc upstairs wants to feed in the small bowel, say, hey, we are. And you need to bring the CORTRAK around to kind of confirm that. Because you don't want to start pulling back. You may never get back, may not get back in the small bowel. All right. Real quick, let's take these quizzes really fast. Like I said, we're gonna take them together. No test anxiety, don't go running out, start crying. Some people.
Don't start crying on us.
Yeah. Cry.
Sorry for